All right, so starting back with steroids. Talk about disease processes, specifically dealing with the endocrine system, but I'm going to talk about steroids in particular because we're going to cover them in a lot of different subjects and they're still going to be the same drug, okay? So I need you to kind of have a grasp of them because once we get to them in other subjects, including respiratory, we're not spending a whole lot of time on them because the drug hasn't changed, okay? Maybe just the form of it, but the indication, but the drug is still the same, okay? Um, so one of the things that we're going to talk about is glucocorticoids, which include cortisone, dexamethasone, fluticasone, methylprednisolone, hydrocortisone, prednisolone, fluticasone, budesonide, and most of those end in that ONE, okay? They affect carb, fat, and protein metabolism. These are man-made drugs that resemble cortisol that's made by the adrenal glands. Usually these are just called steroids. Know that this is different than like anabolic steroids that are abused. They can be given orally, IM, they can be inhaled, they can be intranasal. They are used to suppress hypersensitivity and immune response, which is great when somebody's having an allergic reaction or when we need to decrease inflammation. But they also can be given for adrenocortical insufficiency, which we will talk about. And then know that they can reduce the effect of anti-diabetic drugs, causing increased glucose levels. They can make hypokalemia worse when they're taken with loop diuretics. And then there is risk of GI bleed, ulcer, and perforation. That's increased when taken with NSAIDs or salicylates. They do affect all systems, and I have a slide that goes over that as well. So they can be very useful in patients who have autoimmune disorders or some sort of like anaphylactic reaction, but you have to be careful because they are very harmful to the body. And also, because this is a natural, or they mimic our natural hormones, because our body works on that negative feedback system, if I'm given these, then my body isn't going to produce them. Okay, so it's very important to continue to administer them and to taper them off rather than just stopping taking them. These are some of the forms here. It can be given. So, like I said, when we get into respiratory, we'll talk about this. You can see there's these powdered inhalers. There's regular inhalers. There is a solution that goes into nebulizers. This bottom left is a commonly given IV form of steroid called Solu-Medrol. In that particular drug, I just want to point out, do you see the part that looks like a bulb almost, that's under the gray part? That is fluid. And then below the orange part in the bottom is powder. And so remember we talked about reconstitution. With this particular drug, the way that you reconstitute it, that orange piece is like the plunger on a vial. And what you do is you smush down that gray part. You press down on it and it releases that pressure and it causes the fluid from the top to mix with the powder in the bottom and reconstitute it, and then you can draw it up. In the middle, there is this is a Medrol, I think so, yes, dose pack, which is like a prednisone. You've probably been prescribed a steroid at some point in your life where they tell you to take so many someday and then the next day and then the next day. That's that tapering, okay? Sometimes they're given in this form. And then on the right is a nasal form of corticosteroid, okay? Which helps with inflammation in your nasal passage and your airway. Okay. These are just some of the different forms. Again, most of those end in that own. And then there are some indications here for why a person may be receiving that particular steroid. Okay, so for this topic in particular, what we are going to talk about is supplementing for adrenal insufficiency. Okay, so insufficient adrenals, or is referred to as Addison's disease. Okay, and these people lack glucocorticoids and mineralocorticoids. So because they don't have cortisol, which is that stress hormone, they're going to be lacking that. They could be hypotensive, dehydrated, have hyperkalemia, and a bronze pigmentation. So they need glucocorticoids and mineralocorticoids. Okay, so they'll get hydrocortisone and fludrocortisone. That fludrocortisone, think of that as it floods the body with salt and water, and that is the mineralocorticoid. If we suddenly stop giving them those drugs, they are going to require that forever because their body doesn't make it. And if we suddenly stop giving that, they're going to develop Addisonian crisis. And that looks like severe vomiting, diarrhea, dehydration. They could have severe low blood pressure, also known as shock, confusion, or they can have intense pain in their back or legs. So the treatment for that would be hydrocortisone and IV fluids. Okay. So I don't think I said this, but so I want to go back to mineralocorticoids are aldosterone and fludrocortisone, and they regulate electrolyte and water balance. Okay, on the flip side of Addison's, which is too little, Cushing's is too much. So you got a cushion of steroid, okay? You got too much cortisol. So that's going to look like hypertension. They have truncal obesity. They develop something called moon face. People who have to take lifelong steroids, like people who have asthma, they often will develop that moon face, and it is very distinct if you've seen it. It's very round. They also can get the buffalo hump, which is kind of at the top of their back where their back and their neck meet, and then purple stretch marks. So depending on the severity, we may taper steroids if they're taking them. They may do radiation or medications to lower the cortisol, or they could potentially have surgery if it's excessive. All right, this is just another picture of this. And for the Cushing's, we do want to encourage limitations on fluid and sodium because of the risk of hypertension and hypernatremia. So here's basically just another depiction of what I've already said. Remember that we're not going to suddenly stop taking steroids regardless of why we're taking them, because of the risk of the adrenal crisis, because my body works on that negative feedback. So if I'm supplementing them with steroids, my body isn't going to make them. And therefore, if you stop taking them, your body doesn't have it. Okay, so we're tapering it off so our body's normal function can kick in. If they have adrenal insufficiency, they're going to have to take that forever. Remember that we want to mimic the body's normal process, so we want to give it in the morning for that circadian rhythm. If you've ever taken a steroid, you know it gives you like a jolt of energy. Another important consideration is if somebody has adrenal insufficiency and they're taking supplemental steroids, we We want to make sure that during times of stress, psychological or physiological, whether they're like just stressed out, they're having surgery, they're in the hospital, they're ill, they likely are going to need increased doses to be able to manage that because their body is not producing it, right? So we have to supplement it to combat the stress that they're experiencing. Okay? And then this is a picture of the side effects of steroids. So remember the S's. So sad and swing, sight, slimy tongue, sick, sugar, salt, soft bones. So they can have mood swings, be irritable, have psychosis. This can cause them to be immunocompromised and mask signs of infection, like they may not have a fever. So if they're at risk for infection because they're immunocompromised, what would I want to do? Teach them infection precaution, right? Make sure they wash their hands, make sure they're avoiding likely things that could cause them to become sick. We're maybe implementing like neutropenic precautions and monitoring for signs of illness. Their glucocorticoids will cause hyperglycemia. So if this is given to a diabetic, that's going to be extra important because they may need, if they don't take insulin, they may have to, or if they do take insulin, they may have to take more. I don't know if I said this before either, so I'm going to go ahead and say this here, but if a person has diabetes and they're on insulin and they're in the hospital, because stress can increase our glucose, they may need insulin even if they're not taking it at home. Okay? And then this also causes water and sodium retention, which can cause hypertension and edema. It can cause osteoporosis if given long term. So we definitely want to encourage them to do what? Take calcium and vitamin D, get bone scans, make sure they're doing activity to maintain and kind of prevent or delay osteoporosis. And that they're not taking it long term if they don't have to, like risk versus benefit. There's also a risk of cataracts with long term use, and very important when we're giving inhalers that they can develop thrush or a yeast infection in their mouth. So important for them to rinse after they use before and after they use the inhaler. And they can also use a spacer, which helps it gets it deeper in the lungs versus just concentrated in the mouth. And if they were to develop that yeast infection, what would we treat it with? An antifungal, and we'll be talking about that in this class as well. So remember, we're going to give them early in the day to mimic that circadian rhythm. Give with food to limit the GI distress. Encourage low sodium, high protein, high potassium diet, potentially potassium supplements if they're needed, unless any of those things are contraindicated. And take those infection precautions like reverse isolation. Don't stop abruptly. Tell them to report sudden weight gain, slow healing, black tarry stools, bleeding, bruising, blurred vision, emotional changes, and then those Cushing effects. To know the signs of that adrenal insufficiency, which are fatigue, muscle weakness, joint pain, fever, anorexia, dyspnea, dizziness, fainting, and to avoid alcohol.